The genus Salmonella belongs to the family Enterobacteriaceae and is classified into two primary species, Salmonella enterica and Salmonella bungori. Salmonella enterica is further divided into 6 subspecies, with subspecies 1, known as enterica, containing nearly all human pathogenic serotypes. More than 2,500 serotypes have been identified based on somatic O carbohydrate antigens and flagellar H antigens. These organisms are gram-negative, non-spore-forming, facultatively anaerobic bacilli, typically measuring 2 to 3 micrometers by 0.4 to 0.6 micrometers. Salmonella species ferment glucose to produce acid, reduce nitrates, and are characteristically cytochrome oxidase negative. Most strains are motile and do not ferment lactose, though approximately 1% of isolates may exhibit lactose fermentation. For clinical isolation, freshly passed stool is the preferred specimen, utilized with selective media such as MAC conchi or hectone enteric agar. Bismuth sulfite agar is specifically preferred for the recovery of S. typhi and can detect lactose-fermenting strains. In the United States, non-typhoidal salmonella, or NTS, causes approximately 1-2 million cases annually with a 0.5% mortality rate. S. typhi and S. paratyphi are restricted to human reservoirs, whereas NTS originates from diverse animal reservoirs including poultry, reptiles, and dairy. Multi-drug resistant, or MDR, strains are increasing globally, notably the DT104S typhimurium with the ACSSUT resistance phenotype. Fluoroquinolone resistance is defined by a minimum inhibitory concentration, or MIC, of 1 microgram per milliliter or greater. The infectious dose is highly variable, ranging from 10 to the 6th bacteria in challenge studies to as few as 200 bacteria in some outbreaks. Gastric acidity serves as a primary barrier, and the use of proton pump inhibitors, or PPIs, significantly increases host susceptibility. Pathogenesis requires Salmonella pathogenicity island 1, or SPI1, which encodes a type 3 secretion system for epithelial invasion. Translocated effectors like CypA and CypC induce actin polymerization and membrane ruffling to facilitate bacterial endocytosis. Salmonella pathogenicity island 2, or SPI2, is expressed intracellularly and is essential for survival within the Salmonella-containing vacuole. Host defense relies heavily on Th1CD4, positive T cells and cytokines such as interferon gamma and interleukin-12 for bacterial clearance. NTS gastroenteritis presents with nausea, vomiting, and diarrhea 6 to 48 hours after ingestion, typically lasting 3 to 7 days. Enteric fever, caused by S. typhi, is diagnosed via isolation from blood, bone marrow, or characteristic rose spots. Bacteremia occurs in approximately 8% of NTS cases, with 5 to 10% of these patients developing localized endovascular infections. Chronic carriage is defined as persistence in stool or urine for more than 12 months, often associated with biliary abnormalities or gallstones. Uncomplicated NTS gastroenteritis requires only supportive care, as antibiotics do not shorten symptoms and may prolong carriage. High-risk patients, including neonates and the immunocompromised, should receive 48 to 72 hours of antibiotics, or until afebrile. Severe bacteremia is treated empirically with intravenous third-generation cephalosporins and fluoroquinolones, adjusted based on culture sensitivity. Endovascular infections require a minimum of 6 weeks of intravenous therapy and potentially surgical intervention for abscesses or aneurysms.